Additional Professor at Government Medical College, Thrissur. And we are today presenting the second episode of the KSOS Online Journal Club. Welcome to everybody. With me today here are President KSOS, Dr. Arup Chakravarti, General Secretary, Dr. Gopal Pidle, Chairman Scientific Committee, Dr. Srini, along with the speakers and panelists. And this time, we are looking at a collaborative study, the CLARE trial, from Arvind Eye Hospital, Madurai, in collaboration with the University of California. The study is a continuation in the series of landmark microbial keratitis, especially fungal treatment intervention trials undertaken by Arvind Hospital. And it explores the new innovative method of cross-linking for infection reduction in fungal keratitis. So the presenters will be Dr. Mathew, Assistant Professor, RIO Trivandrum, will be presenting the paper. Dr. Smita Narayanan, Editor, Kerala Journal of Ophthalmology, and Additional Professor at RIO Trivandrum will discuss the statistics. Dr. Anil Radhakrishnan, Consultant Cornea and Refractive Surgery, Associate Professor, Department of Ophthalmology, Amrita Institute of Medical Sciences, Kochi, and Dr. Sujit Nayanar, KSOS Scientific Committee member and Medical Director at Trinity Eye Hospital, Kozhikode, will be giving the clinical interpretation. And towards the end, the chief author of this paper, Dr. Prajna himself, will discuss queries from our panelists in a video commentary. And so before we start, let me invite the President for a few words.
A warm welcome to all the viewers from the President KSOS. And thank you, Dr. Gopal, Secretary KSOS, Dr. Srini, Scientific Committee Chairman, and then Sudha for organizing the journal club so well. We are on to the second episode of the journal club. The first one was received extremely well. There have been wide viewership from across the country, and we have received glowing tributes about the first journal club. So I hope we even excel, we do better than what we had done during the first episode. And I'd like also to thank Dr. Smita, Dr. Mini, Dr. Sujith, and Dr. Anil, for taking their time out, and they're brilliant ophthalmologists, great academicians, and I wish this program all the best.
Thank you, sir. Dr. Gopal.
Thank you very much, Dr. Sudha, for spearheading this program, which is Dr. Arup's vision of bringing a journal close to the Academy of Ophthalmology in Kerala and widespread. I'm sure that these journal clubs will spread wide, far to other continents also, and will gain great accolades. Thank you very much for doing this program month after month. All the best.
Thank you, Gopal, and over to you, Dr. Srini.
Thank you, Dr. Sudha, for organizing this. As Dr. Arup said, the first episode was runaway hit, wide audience, and I'm sure that this one is also going to be really good with Dr. Smita, Sujith, Anil, and Dr. Mini. They're going to do a great job. All the best for this program. Thank you.
Thank you, everyone. And now over to you, Dr. Mini, for presenting the journal.
Is my screen visible? And it is?
Yes, please start.
A very good evening to one and all. I would like to thank KSOS and Sudha Madam for giving me this opportunity. So as Madam had already mentioned, this is an article about cross-linking assisted infection reduction. This was a randomized clinical trial evaluating the effect of an cross-linking on outcome. So a little background of keratitis in our population. In South India, the incidence is 130 per 1 lakh. The incidence of microbial keratitis in India is 10 times that of the US. And an estimated 8 lakh persons develop microbial keratitis in India every year. So as per the Asia Cornea Society Infectious Keratitis Study, which was done at 13 tertiary eye care hospitals, they reported a fungal predominance in India. Now coming to the background literature search, as we all know, the landmark study, that is the MUD trial, which was sponsored by the National Eye Institute, conducted in southern India, Madurai. They found out it was done to determine if natamycin or voriconazole resulted in a better outcome for fungal corneal ulcers. So they found out that with filamental fungal keratitis, particularly fusarium, natamycin had a better outcome than voriconazole. The MUD-2 trial was conducted to study the benefit of oral voriconazole in addition to the topical antifungals. So they found out that for filamental fungal ulcers, actually the addition of oral voriconazole does not provide any therapeutic benefit. But in the case of fusarium, it causes an additional benefit. Now, on literature search of collagen cross-linking in the management of advanced non-resolving microbial keratitis, that is both bacterial and fungal, they found out that cross-linking appears to be an effective procedure in the management of superficial microbial keratitis. This study was done by Shetty et al., and they found that it can be used as an adjunctive treatment in treating non-resolving microbial keratitis. In this study also, where they used collagen cross-linking in the treatment of advanced infectious keratitis with a corneal melt, they found out that it could be an effective adjuvant therapy. In vitro efficacy of antifungal combined with riboflavin was also proved. So our research question comes to determine if there is a benefit to the adjuvant corneal cross-linking to compare natamycin versus amphotericin for filamental fungal keratitis. So what was the primary outcome they measured? At 24 hours, the primary outcome was the culture negative result. And the secondary outcome was the best spectacle correctal visual acuity at 3 weeks, 3 months. Then the epithelial healing, the size of the infiltrate, the scar was done at 3 weeks and 3 months. And in addition, a 3-day smear and culture result was taken. All the adverse effects of corneal perforation and if the patient has gone to a therapeutic was also recorded. So all the study participants were enrolled at Adjuvant Eye Hospital, Madurai. They included all the smear-positive fungal corneal ulcers with a presenting visual acuity of 20/70 in the worst eye. These participants were randomly allocated into 4 groups. That is, the first group was natamycin alone, second, nata with cross-linking, third, amphotericin alone, and fourth, amphotericin plus cross-linking. So all the patients received either topical natamycin or topical amphotericin B. Now, each eye was randomly assigned and a particular adaptive randomization allocation using block randomization was done at the coordinating site. A double masking was done. The study participant was not masked to their cross-linking intervention. The microbiologist, the treating physician, and the refractionist performing the best corrected visual acuity was masked to the treatment arm and also masked to the medication assignment. Interventions were recorded as per the mycotic ulcer treatment trial, and the scraping was done at enrollment 24 hours and 3 days by a masked microbiologist. It was done by a chimeral spatula with aseptic techniques. 2 scrapings were directly done onto 2 separate slides for Bramstein and KOH, and also for blood agar, chocolate agar, potato dextrose agar, or Sabrot's agar. A positive smear was defined as the fungal element seen under low power magnification. And positive fungal culture was defined as a light growth on any of the 2 media or a moderate to heavy growth on a single media. Now, how was the cross-linking done? And within 24 hours of the enrollment, 30-minute loading dose of 0.1% riboflavin and 20% dextran administered every 2 minutes. Then he was exposed to UVA light. Throughout this UVA treatment, the participant received riboflavin at 5 minutes interval. The patients were hospitalized for the first 3 days. Then the readings were taken at baseline, 3 days, 3 weeks, and 3 months with a slit lamp bimicroscope. Now coming to the baseline characteristics. 403 patients were screened between 2016 and 2018. Out of these, 111 patients were randomized to the 4 treatment arms. So what was the result got? Fusarium grew in 42% of the patients. Aspergillus grew in 14%. The culture results were negative in 22 of the patients. Now, this is the baseline characteristics with regard to the sex, age, occupation, presence of trauma, the ulcer location, presence of hypopion, depth. Now, coming to the results. So if you have gone through the article, you can see that most of the results were not statistically significant. So out of this, those who were randomized to cross-linking, they had 1.32-fold increase of 24-hour culture positivity, but this was not significant. They were unable to detect any difference in visual acuity among those randomized. And also those who were randomized to cross-linking, regardless of the medication, he had a higher odd of an epithelial defect, but at 3 weeks and at 3 months, but that too was not significant. So this is a chart showing the primary and the secondary outcomes with respect to the culture positivity in the 4 treatment arms at 24 hours and 3 days, the smear positivity, the visual acuity. Visual acuity was taken in the median with an interquartile range. So this is a logmark chart with the time duration, that is baseline 3 weeks and 3 months. So the statistically significant result that they got actually was that those who were randomized to cross-linking had a 0.32 logmark worse visual acuity at 3 months. This was found to be significant. With regards to the visual acuity in the natamycin and amphotericin arms, regardless of whether they had cross-linking or not, there was no difference. It was not significant. Adverse events were recorded, such as corneal perforations, those who had gone to a therapeutic keratoplasty, then, but all this were not statistically significant. So what did they find out? There's no actually benefit of an adjuvant cross-linking. All these results were not significant actually. And multiple studies, they actually showed the efficacy in vitro and in vivo for bacterial keratitis. But for fungal keratitis, there is no evidence. What are the limitations? The patients, as you know, were enrolled from India. So majority were exposed to agriculture and not contact lens wear. Then the antimicrobial effect of CXL could have been taken at a 3-day culture. Then actually the randomization procedure that was done was found to be not very different from the routine one. And data suggests that UVC could be a more effective treatment. Thank you.
Thank you, Mini. Could you stop sharing? Okay, now inviting Dr. Smita to discuss the statistics.
Thank you, Dr. Sudha. Good evening, ladies and gentlemen. The journal club, the purpose of the journal club is twofold. One is to critique the paper, that is to find the good points and the bad points about the paper. And second is to learn something new from the article. So let us do a critical appraisal. And for that, first, let us look at the title of the study. The title of the study is a randomized clinical trial evaluating the effect of cross-linking on outcomes in fungal keratitis. So this is a randomized clinical trial, an RCT, and therefore we take a 2010 consort checklist with us. This is the checklist for information to include when reporting a randomized trial. You know that for different types of clinical trial, we need different checklists, and consort is the checklist for the RCT. So first, let us look at the title and the abstract. We see that the title is a good replica of the purpose of the study. Those of you who have gone through the article and through the abstract would have noticed that the abstract notes most of the stuff that is there in the article. But many times you may have come across studies where the abstract has no bearing upon the contents of the article. So this is good. The study has, in its introduction, summarized the reasons why they have taken up the research question. That is succinctly summarized. And so when you look at the research question, it is to determine if patients randomized to cross-linking with medical therapy will have a higher prevalence of negative fungal cultures at 24 hours than the patients who received only medical therapy. So here they were comparing only moderate-sized ulcers caused due to filamentous fungi. The second aim was to compare natamycin with amphotericin B along the same lines. Now, looking at this research question, I feel that this is a superiority trial, even though they have not explicitly stated it. We can see this research question in the PICO format, where the P is the participants, and they are the consecutive patients who were smear positive for fungal corneal ulcers. The intervention group had the antifungal drops plus cross-linking, while the comparator group had only the antifungal drops. The outcome was the culture negative status at 24 hours. This was a single center study, and they have said that the outcome assessors and the participants were masked to the medical assignment, the medication assignment. Now, is a randomized controlled trial a good or an appropriate study design for this kind of a research question? I think it is a good study design, because a randomized controlled trial is actually meant to compare the effectiveness or compare the efficacy of different kinds of interventions. Also, an RCT is prospective in nature, and therefore that is of additional benefit. Now, in this study, they have said that this has a 2x2 factorial design. Now, what is a 2x2 factorial design? It is that the trial has two arms, the cross-linking arm and the medical therapy arm. And each of these arms is further divided into two. So the cross-linking arm is divided into natamycin with cross-linking and amphotericin with cross-linking. And the medical therapy arm is divided into natamycin and amphotericin. The advantage of this 2x2 factorial design is that you need fewer patients as compared to a traditional 4-arm study, and therefore the cost of study is lesser, but the results are the same as that of a 4-arm study. We also see that they have utilized an adaptive randomization allocation using a special format called the drop the loser approach. Usually, when we do a traditional randomization controlled trial, the allocation is done by a process called randomization. But here, in this adaptive randomization allocation, the investigator gets a second chance to modify the trial or the statistical procedures based on the interim review of data when the trial is ongoing. The only thing is that they have to meticulously update in real time all the data that is being used so that the trial can proceed smoothly. Now let us look at the outcomes in greater detail. The primary outcome measure is microbiological cure on repeat culture at 24 hours. Now, is that an appropriate outcome for this study? Now, as a general ophthalmologist, I feel that instead of a microbiological outcome, they should have used a clinically appropriate outcome. A clinically appropriate outcome, like the time taken for epithelial healing or the size of the scar or infiltrate at a particular duration, or the visual acuity. They have tried to justify it by saying that they wanted to isolate the effect of cross-linking in infective keratitis, as medical therapy tends to decrease the effect of culture positive rate over time. Then the question arises, do you really want to isolate the effect of cross-linking? And if they really want to, then this trial can tell you if this has an additive effect. But if it has a synergistic effect or a dyssynergistic effect, that is not quantifiable by this trial. Secondly, if you are using a microbiological result as the primary outcome measure, then you have to consider the accuracy of the culture results. They said in their study that positive fungal cultures were identified as light growth on any two media or moderate to heavy growth on one medium. Light growth on any two media. Now that is very subjective, and I think that is a point for bias, especially when you are using natamycin eye drops, and you know that natamycin leaves white precipitates on the surface of the ulcer. And even though you're claiming that the microbiologist who is performing the repeat scraping and culture analysis is biased, is blinded, I don't think that is very realistic. Thirdly, should the study have included only smear and culture positive patients at baseline instead of only smear positive? They have included this fact in the sample size calculation, but I think culture requires time, and that is why they have not included this. Now let us look at the sample size calculation. Now, sample size calculation was based on certain assumptions which were derived from the investigators' experiences from conducting previous trials, especially the mycotic ulcer treatment trial 2. Now, we do not know if these assumptions are actually applicable here or how much of it is actually applicable here. The assumptions are actually mainly 3 or 4. One is that 15% of smear positive are culture negative at baseline. This was what we discussed in the previous slide. 7.5% reduction in culture positivity occurs per day of treatment. And most importantly, they have assumed that 80% would be culture positive in the medical treatment group and 50% in the cross-linking group. So in order to detect an effect size of 80 minus 50, that is 30%, they have an alpha of 0.0125, and the power was not specified in this study. And they have anticipated no loss to follow-up at 24 hours. And they have calculated that they need 110 patients to be randomized into 4 groups. We will come to that later. Now, what are the statistical methods used in this study? In this slide and in the next slide, I will just describe the statistical methods to know what it exactly means. So usually the table 1 in a given study tells us about the baseline demographic and clinical characteristics. And here the same thing is described for the 4 groups. Now, if the variables are categorical, like the gender or occupation, and if the number of participants in the group is small, then the test used to analyze the differences is the Fisher exact test. If the variables are continuous, like the age or visual acuity in logMAR, then, and we don't expect its distribution in fungal corneal ulcers to be normal, then the best test would be a rank-sum test, that is the Wilcoxon rank-sum test. Now let us look at the primary outcome measure. It is the culture status of the patient at 24 hours. That is a categorical variable. Here, we need to establish an association between the culture status and the intervention, and if possible, a cause and effect relationship. Now, to make the statistical purpose easy, we convert the culture status into a binary or a dichotomous form, and that is culture positive or culture negative. And this then becomes the dependent variable. The independent variable is any of the 4 groups in the intervention, and again, that is a categorical variable. To establish association or causality between categorical variables, we use a logistic regression, and the type of output is the odds ratio. In case of continuous variables, we use a linear regression, and the type of output is a B coefficient. You can also do multivariable regression by adjusting the influence of all other confounders. And when the outcome has a time component to it, then we do a survival analysis with the Cox proportional regression model. Let us come to the results. we use the consort flow diagram. And here we find that 403 smear positive patients were assessed for eligibility. And as Dr. Mini showed, out of them, 111 were randomized to 4 groups. So even though the study investigators claim that there was no loss to follow-up at 24 hours, we find that around 6 patients were lost to follow-up in the first 24 hours. Secondly, in the table 3, they have said that table 3 is actually the one which shows the primary and the secondary variables. They have said that at 24 hours, they were not including any culture negative patients, but here we see that they have included culture negative patients. And again, no explanation has been provided for this. Now let us come to the results. The most important statement in the results is that those randomized to cross-linking, regardless of medication, had 1.32-fold increased odds of 24-hour culture positivity. The 95% confidence interval was 0.57 to 3.06 with a p-value of 0.51. And this was not statistically significant. So what does this mean? This means that the odds of getting a culture positive result in the cross-linking group was 32% more than in the medical management group. And since it is greater than 1, it is a positive association. The odds ratio is usually reported with a p-value and a 95% confidence interval. The p-value shows us the statistical significance, and the 95% confidence interval tells us the spread of odds ratio in 95% of the study population. If this 95% odds confidence interval spans across 1, then it is not statistically significant. So here we find that the 95% confidence interval of 0.57 span to 3.06 spans across 1, and therefore the p-value along with it is greater than 0.05. And therefore, this result is not statistically significant. The second important result was that the best spectacle corrected visual acuity was approximately 0.22 logmar, worse on average at 3 weeks amongst those who received cross-linking regardless of the medication. And the 95% confidence interval was minus 0.04 to 0.40 with a p-value of 0.04. So here we see that the confidence interval does not span across 1, and therefore the p-value is less than 0.05. The p-value is showing statistical significance. The discussion has been ample, and they have discussed the trial limitations very well. Now coming to the second part of a journal club, that what did we learn from this trial? We learned that cross-linking with medical management did not give any benefit in the treatment of fungal keratitis, and the visual acuity actually worsened. Now, since this was by a randomized controlled trial, we find that the evidence provided by it is quite high. So I would like more such randomized controlled trials with similar primary outcome measure to be performed, and then a meta-analysis of them to get a conclusion so that I can adopt it in my clinical practice. However, I would also prefer a clinically relevant primary outcome measure, a more realistic effect size, and also real-world assumptions. And more importantly, I would prefer a more robust data collection and management. Thank you very much for your kind attention.
Thank you, Smita. That was an excellent synopsis of our study. And now for the clinical discussion, over to Dr. Sujit Nayanar for initiating it.
Thank you, Sudha Madam, and KSOS for giving me this opportunity. Actually, it's a learning experience for me by taking part in this journal club. And a very good article has been selected, and really a question that most of corneal practitioners are actually thinking of starting or not to start cross-linking in our clinical practice. So a very authentic study from institute by a very reputed investigator. So it is worth discussing such a paper in this forum. So before we go into the details of this paper, I think we must know the prevalence of this clinical condition. Dr. Mini was actually mentioning that like in India, we have almost 10 times the cases of fungal keratitis or microbial keratitis than the US. But most of the time we look to the papers from the West to decide clinical matters. So Dr. Mini has got one publication in this respect, and I think we can have a quick discussion on that regarding the status from that paper.
Thank you, sir. Actually, at RIO, we had done retrospective studies of corneal ulcers. And one study that was published, it was the retrospective study was done from in August 2018 to July 2020. And it was the clinical characteristics and predictors of microbiologically proven mycotic keratitis. So out of the 165 patients that the case sheets that we had studied, 47.9% was from was fusarium, and 44.9% was aspergillus. So at that period of almost spanning 2 years, we had culture positive fungal keratitis. And we had another retrospective study which was done 2018 to 2019, and that included both culture positive and culture negative patients. So out of 375 patients that we studied, 45% were culture positive. Out of this this percentage, that is almost 125 patients were culture positive. This 15% showed fusarium growth and 9% was aspergillus. So out of those who showed deterioration, that is the predictors of the deterioration were studied. So out of the the ulcers that showed deterioration, 12 out of the 15 ones were fungal ulcers. And the more commonly involved ones were fusarium and aspergillus. So this was the background of what we had done. Thank you.
Thank you, Dr. Mini. Any observations on the complications or the outcome of these cases in your study?
Yeah, I think the major observation that we did was those who were already on a pre-treatment, it was difficult to find a culture positivity in them. And also those who were culture proven, there's only a tendency to a better outcome, but we couldn't prove that it was a better outcome. So the question remains about is it relevant to do a culture for each and every patient or those who are on pre-treatment? And we also found out that the predictors were those who are larger ulcers, central ulcers, already worse visual acuity on presentation, like that.
There's a very key point which you have told, the pre-treatment. So most of the time we see that non-judicious pre-treatment actually makes the thing more complicated, and it may affect the primary outcome, the outcome of the treatment. So Dr. Anil, sir, can I come to you? Like, why fungal keratitis management is still challenging for us?
Yeah. Thank you, KSOS, Smita ma'am, Sudha ma'am, and everyone for the opportunity. I think Journal Club is a big step forward for the society. So I think fungal keratitis is definitely under diagnosed and undertreated, and quite often it is managed at the later stage when usually you end up in complications. The incidence, the prevalence of fungal keratitis is very high in our population. With an apology to Dr. Sudha, she wanted me to get data from the last few years for me, but I think only the initial data I have, that is about 1.5 years. I think we had looked at around 144 patients in Amartya Institute to just give a pattern of what the prevalence of the particular keratitis over here. I think microbiological positivity was seen in about 75% of people. So I include both smear as well as culture positivity. Culture positivity was seen in about 63.5% of people. And I think maybe because it is a big hospital and you have slightly more higher incidence of exposure keratopathy and stuff. The organisms that we found more was this gram-negative bacilli. I think the incidence of exposure keratopathy was slightly more in our series. But if you look at individual species, both bacteria and fungi together, Fusarium was ranking first. Fusarium had the maximum number of cases. And most of the fungal keratitis actually came pretty late. And 6 out of 10, I think, required, of the Fusarium cases, required keratoplasty. So, which tells you that it's very important to treat it properly in time. And steroid use was seen in quite a lot of people who were having fungal keratitis. I think quite often a combination of dexamethasone and antibiotic was given in the initial stages. And that is a pattern quite often we see that when you give steroids in the initial period, somehow things get out of control. You know, the fungal keratitis, it's very difficult to control. I think the same holds good for mycobacterial keratitis. Other thing, I think if you want to say, if you should not, as Sujith was mentioning, we should not take Western data for our population. I think the studies from Aravind, Shankar Nethralaya, RP Center, and LV Prasad Institute, all the institutes have really proven that fungal keratitis is a major pathogen in our situation. And in South India, definitely fungal, if you look at the tertiary institutes, fungal keratitis is the predominant pathogen as compared to bacterial.
So yes, sir. So the few points which we are stressing here is like we do have higher prevalence of fungal keratitis, and of them, mostly the culture proven, we see Fusarium as the predominant filamentous fungus that is involved in the fungal keratitis. Probably we are all seeing it at a later stage, and probably not treated initially at the right time or with the right medication, over use of steroids. These things are probably complicating the clinical scenario, making the diagnosis or culture positivity a little difficult in situations that are coming late, and ultimately leading to perforations or a need for a therapeutic keratoplasty. So probably in this, the background of this article, if you think like we are looking for some adjuvant therapy that will help. So I would like to ask sir for a comment on the current available antifungal agents. Like how do you start? We can have a quick comment on how do we actually start, because it is not practical to wait for. We don't look at the sensitivity in fungal cases. We don't. Most of the cases, most of the times, we don't look for a positive culture report also before starting the antifungal. Probably we start with a smear report. So how can we just start, for the benefit of a comprehensive ophthalmologist, how can we just start antifungal, which medicine, and any comment on that before we go with the other details?
Yeah, according to that Asia Keratitis Study Group recommendation, every case should be taken for every patient should undergo a corneal scraping. And I think based on the smear only, we can make a diagnosis. But that may not be possible in all the cases, especially in slightly, if you take a patient from Wayanad or Idiki, it's not possible. They cannot go to travel 100 kilometers to a city to do a scraping. So I think based on clinical findings, you can start, at least if it is early enough, we can start it. I think one of those articles from CMC Vellore, I think way back in, I think before 2000 somewhere, Dr. Thomas had published that. And he was telling three things. One is the raised nature of the infiltrate. Second is the high fade margins we are all familiar about. And the grayish white color or non-yellow color. That's what he mentions in the article. So these three, one point on its own, like if you have it, it has a 63% chance of diagnosis of fungal keratitis. If all the three are there, the chances would go up to as high as 83 or 85%. So based on clinical diagnosis alone, you can pick up cases in the early stages. But once it goes beyond a certain stage, the clinical findings cannot be relied upon. That is one very important thing what we have to remember. Only in the initial stages, without modifying virgin cases, without being modified by any medications, then maybe you can make a and take a call based on the clinical features. But otherwise, it may be very difficult. So I think there was another one very interesting study again done by the Arvind Eye Care team, in which they had people from I think Proctor Foundation as well as from Arvind Hospital, all pretty senior cornea specialists, and they were asked to make diagnosis based on the clinical appearance. And they found that only about 65% of them, that means less than two-thirds of them could diagnose it properly. So in moderate or large ulcers, we cannot depend only on clinical findings. But in the very early stages, maybe yes, this can give clues. But the main limitation regarding the treatment is the paucity of the antifungal agents we have. Regarding the antibiotics, we have at least, even though the new antibiotics coming up are less nowadays, even then we have quite potent antibiotics, and a lot of them are, if you are using it in fortified way, I think it is quite efficient, even though the antibiotic resistance is there in a significant amount of cases. But in fungus, the problem is the penetration of the drug. The best drug that is available, as is well elucidated in all the studies, is natamycin. But natamycin, it does not penetrate deep into the stroma. So that is one major limitation. The other things that is available is voriconazole. We know that now it is inferior to natamycin. Voriconazole and in fact all other azoles work well in Candida species. If you look at the standard textbooks, they promote the use of fluconazole and all that, but fluconazole actually works only against Candida, which forms hardly not even 5% of keratitis in India. So against filamentous fungi, it doesn't work. That it is as simple as that. So we have to be aware of that. We have to be aware that our geographic location is very different from the temperate climates. And we should depend on our data to guide our treatment. That is something very important.
Very relevant points. Very relevant points. One, you want to add something? You were about to say something.
No, like the new drugs are hardly anything is there. Even the new drugs that are coming, this echinocandins and all that, capsofungin and all that, postconazole, soconazole, all those are active mainly against Candida. It does not work against our filamentous fungi.
The most relevant point here is like we have very less antifungal agents to work, play around. The most available one is natamycin. That is the first drug of choice, but it has got a disadvantage of poor penetration into the cornea, especially in the deeper ulcers. So it is recommended that you do repeated scraping so that it can facilitate the normally the reepithelialization is taken as a sign of healing ulcer, but even in that you're supposed to do repeated deepithelialization so that the drug can penetrate into the stroma. Other medicine that is probably amphotericin is equally efficient, but thing as Anil sir told, you need to reconstitute it in a periphery and periphery or a non-institutional practice. It may not be that easy or available, and it's a bit costly also. Then the third drug, or probably the second drug for a comprehensive ophthalmologist normally choose is voriconazole. But once it was, I think, in way back in 2006 or 7 that later, but that is when the voriconazole actually came into practice, and there was huge interest in voriconazole. But that interest has actually waned off over the years. The effect is inferior to natamycin. It is actually shown to have an adjuvant role to the natamycin nowadays, and probably in injections like intrastromal or intracameral, if you are adding along with the natamycin, if you think that it's a deeper ulcer or there is an endothelial plaque, then probably you can use it as a agent. And another important point here is that voriconazole is found to have increased resistance over this also. Probably with this background, that is why the clinicians or the researchers are more interested in looking for a what you call an adjuvant therapy for a fungal keratitis to support the primary therapy, like antifungal with starting the treatment with antifungal with natamycin. In this context, cross-linking has gained a lot of interest in the last few years. Why cross-linking is thought of as an adjuvant in this treatment is like probably you know the basics of cross-linking. It is a photo activated riboflavin that is being put into the corneal stroma. It produces free oxygen radicals. It tries to cross-link the collagen fibers and make it more stiff and make it more resistant to the collagenase enzyme, so that it doesn't, the collagen doesn't, the cornea doesn't melt or perforate. Apart from that, the riboflavin, the photoactivated riboflavin has got some activity, antimicrobial activity also by affecting the RNA and DNA of the microbes. All these things, it is very clearly proven in the in vitro studies. And now it is the stage of trying out in the in vivo studies. And that's when we see various reports coming up, and the importance of this study being a randomized control study. We have very less randomized control study on this particular topic of cross-linking in microbial keratitis. So, one more quick comment from Dr. Anil, like, is the timing of this intervention? That is one important point. Like, we are saying it as an adjuvant therapy. So at what time of the ulcer? Is it at the beginning of the ulcer, or like the inclusion criteria? We saw the inclusion criteria in this particular study, but can we have some discussion on that part? Like, when should we consider cross-linking as an adjuvant in antifungal treatment in the current scenario, whatever evidence we have got now?
I don't know whether I'm good enough to make that give the comment about it. But the thing is, it will be a personal comment. That's all I can say. Because there are no proper guidelines or proper data-based recommendation that I can tell you. But I think if you see that your regular treatment is not working, I think you should add a second drug. Just like that, if you add natamycin, that is one particular group of drug that you're using. It is acting on the ergosterol group. Second thing that you can add is the azole group, or voriconazole or anything like that. So if natamycin alone is not working, you should add voriconazole. I think something similar to that, you can add a cross-linking if the natamycin, regular natamycin is not working. That's what I would place it.
So that is one point which needs to be highlighted. Like, if natamycin is not working, or if you think that natamycin is not working, what to be added, when to be added. So very important point, sir. Voriconazole is the next drug you should think of. As Anil sir told, most of the time we see a lot of azoles being added, like fluconazole, ketoconazole, itraconazole, everything being added just to add to the medicamentosa part, and it will not probably help in filamentous keratitis. So voriconazole is the next important addition. But there are certain, when you are thinking about cross-linking in fungal keratitis, obviously your question is whether it should be added early in the stage or in the later stage, before the cornea starts melting or once the cornea starts melting, whether in the superficial corneal infiltrates or in a deeper infiltrate. And you also should know whether there are any strong contraindication for cross-linking in this. When we start from contraindication, there is clear contraindication is already perforated cornea, you don't use it. In a suspected co-infection with herpetic ulcer or a past history of a herpetic ulcer in a particular patient, it is a strong contraindication. And regarding the other two, superficial versus late, it's again, like Anil sir told, there is no clear guidelines. There have been studies in the superficial keratitis as well as the deep keratitis. Based on these points, actually, Dr. Smita had asked, and Dr. Smita madam and Dr. Sudha madam both had asked few questions were raised, and these questions were put up to the author, first author, Dr. Venkatesh Prajna. And we have got a short video to share with you from the chief author himself regarding a few explanations for the questions or the queries which we asked. So can we have that video, please?
Good evening, everybody. At the outset, I would like to thank KSOS and Dr. Sujit Nayanar for this opportunity to converse with you today. I'm very sorry that I cannot be in person or in live because of prior pre-commitment on this specific day. What I thought was I'll just use this 5 minutes to give a broad view on how this whole research experience has been for me, and also try to answer some of the questions which have been raised by some of the KSOS members pertaining to this specific study. So when I first did these studies, the drug trials, it was disappointing because the results were not that great. Both natamycin, amongst these two drugs, natamycin was better, but that didn't mean that it was a solution. So we were looking for other opportunities, and my first randomized control trials in the field of cross-linking was when we published in the BJO with my fellow Madhu Daraju as the first author and I being the corresponding author, where we actually randomized deep recalcitrant fungal keratitis into two groups, one which received cross-linking and the other group which did not receive cross-linking. And both of them got natamycin. And the group which received cross-linking had a 75% perforation rate. And we had to stop the study midway because it was such a high perforation rate. We published that results in BJO saying that the cross-linking does not work in deep recalcitrant fungal keratitis. And immediately in the next edition, we had a letter from Dr. Hafezi, whom you know is a big name in the field of cross-linking. He had criticized our study, saying that these authors took deep stromal keratitis, which anyway would fail treatment. So that made the cross-linking worse. Now my thinking was, for a superficial ulcer, you don't require a cross-linking, right? You just require natamycin alone. For a deeper ulcer is where we are looking for solution, and that is the reason why I took that. So when we got that criticism, which was also right in a certain perspective, we said let us do on all cases of fungal keratitis, leave alone the mild forms. And that answers the first question of one of the KSOS members who had asked me, why did you choose only moderate ulcer? We did not choose a severe ulcer because we were criticized in our paper. We did not choose a very mild ulcer because it is too mild, it's amenable to medical treatment, does not require a cross-linking. The second question raised by some of the members were, why do you do culture at 24 hours? Wouldn't it be nice if you had done culture at 72 hours? We had discussed the same in the discussion part in this paper, because as you know, we were also using antifungal drops. So we did not know whether the antifungal drops were working or the cross-linking was working. And so the effect of cross-linking we wanted to measure, and so that is why we thought we will use a 24-hour endpoint. Now, this is not a perfect answer, but then I told you about one disadvantage of doing a randomized control trial is the rigidity. You have to have some sort of a measuring point. Now that might sound logical, that might not sound logical, but you have to have some sort of a measure. And so that was the reason for the 24-hour culture positivity or negativity for this study. The third important thing is, whomsoever raised this question, I really want to thank him or her because they found out a mistake in our paper. They've asked us why were smear negative, 2 patients with smear negative were included in the baseline data. A fantastic review by that member. I am really thankful for that member for pointing it out. This article went for 3 reviews. None of the international reviewers picked up this deficiency. Your KSOS member has picked up this deficiency. I acknowledge this and I'm thankful for that gentleman or lady who has pointed that out. In fact, Sujith can do a favor and let me know who that person was so that I can personally thank them for finding out this mistake. So the other question which was raised by the members were, how were you sure whether, since you just went by smear, how were you sure that there was no coexistent infection? Possible, but in real life scenario, the coexistent infection are less than 6 or 7%. It doesn't matter much when you're doing a large-scale randomized control trial. There is a possibility, but you have to have a starting point and you have to have an ending point when you're doing research. And so that is why sometimes it might not be completely relevant. It may be mostly relevant. And so that is the advantage and disadvantage of doing a randomized control trial. Another member wanted to know, why did you have the age limit between 18 and 70? The reason why we had an upper age limit was usually to ensure follow-up. You don't want really old people into the study because it was almost like a 1-year follow-up. So that is where we just arbitrarily fixed it up at 70. And anything less than 18, you need to take additional consent. And we also felt that it is not fair to do these trials when we are doing it in a trial mode on children. So what's the future? The future is this finding pertains to the methods used in this study. So it was conventional resident protocol, ultraviolet light and riboflavin, point period. So this does not mean that cross-linking will not work. In fact, we are now embarking on a larger randomized control trial where we are using rose Bengal and we are using a green light. And this is an NIH sponsored study, again between 3 institutions, Bascom Palmer, Aravind and UCSF. And so we hope to answer your questions with regard to using rose Bengal and green light. But then there is a lot of interest in light being used as a therapeutic regimen for infections, not in ophthalmology, but a lot in plastic surgery. And those are like deep UV lights, not the regular UV lights, but deep UV lights, which are less mutagenic. So there is a future to this. So we are just saying that in this current resident protocol with riboflavin, it is not that great for fungal keratitis, but for bacterial keratitis, we see good response. So it doesn't mean that we are telling it for entire infectious keratitis. We are very, very specific that this pertains to the methods used in this study for fungal keratitis. Once again, thank you very much for giving me this opportunity to be explaining to you in little bit of detail about my thought process with regard to this study. Thank you once again.
Sincere thanks to Dr. Prajna, who readily accepted.
Dr. Sujith, can I interrupt a minute?
Yeah, yes.
I'd like to just, of course, this is a great video and a great congratulations to Dr. Smita Narayanan, who's actually detected this flaw in this study. So it's really good. There is a question to Dr. Smita in the chat box, in the YouTube. Actually, they're talking about the p-value and the confidence interval, and where you said that the confidence interval acts like a indicator that if it crosses over 1, it should not be significant. So Dr. Prashov has asked whether that is acceptable in the case of odds ratio. So should you look at only the p-value, or is the confidence interval also suggesting that it is not statistical significance? You're mute, Smita.
From what I understand of the question, the confidence interval tells you about the spread of that odds ratio or whatever parameter we have measured in the study population. So if the confidence interval is too wide, then the p-value will be the p-value which is actually testing the chance of that result to be statistically significant. The p-value would be insignificant, not statistically significant. So confidence interval, if it is narrower, then the p-value is, the chance of the p-value being statistically significant is higher. So when we look at a confidence interval, it is actually telling us where is that value going to lie in the study population. The p-value is the one which actually tells us whether it is statistically significant or not. This is what I understood from your question, Sudha. Is there anything else?
That is what, but it also suggests the confidence interval, when it says that it crosses 1, it suggests that the true value of the population could be more could be less or could be the same.
Yes.
So that is why we are saying that it doesn't really indicate significance, since it could be distributed in all of these values and all the true values could be true. That is why it is sort of indicating your significance. Okay, over to you, Sujith. Please, we are running short of time. Just let us find out.
So let me use this time to thank Dr. Prajna, who readily accepted our invitation to give a small video. He was supposed to come, but he couldn't come personally. So I'm online. So thank you, sir, for giving a good comment. So what he was actually saying is the practical points, like the rigidity of the study point, especially when they have used it in the, to sum up what he have told, like when they used it in the deep ulcers. So in superficial ulcers, we have other options. So we are not looking for any adjuvant option. So that is why they started with the deep ulcers. When the deep ulcers, they were criticized for causing complications and all. So that is one point, like whether from this study, we understand that if at all we are using cross-linking, we are supposed to use it for a moderate ulcer, which we think that may not be amenable to medical treatment alone. Second thing is the 24-hour endpoint. Again, this is possible only in a constitutional, institutional practice. I don't think how far it is practical in our private practice. And if you are thinking of putting it into your private practice, the two main things that will come as a hindrance will be the availability of the cross-linking machine. Second thing is will be the cost involved. So for a moderate-sized ulcer, you are suggesting a cross-linking alone, because if you are again in this study, they have told that they have used it along with the natamycin. So how far you can prescribe just cross-linking as a treatment, it's still a question mark. It cannot be put. But there are in vitro studies that are showing good results in bacterial keratitis, especially, but also in the fungal keratitis. Sir, Anil sir, have you gone through that Narayanan paper regarding the? I think Dr. Mini had shown that in one slide.
Yeah, Dr. Shetty and all. No, yeah. No, I have not gone in detail. I just read the abstract some time ago.
So in that, they have specifically told 3 fungal ulcers. They have just studied 3 fungal ulcers. Others were bacterial ulcer. But in that, one point I would like to stress is that that included cases with endothelial plaques also, which resolved and finally had a very good outcome by scarring. One point which they mentioned is, and which probably other studies also mentioned, is there is increase in hyperpion after the cross-linking. A case which initially didn't have a hyperpion actually resulted in having a hyperpion after cross-linking, which they found as a something like a new observation after trying this treatment. So, Sudha, madam, any other points which you want to bring into the discussion part?
I'll finally just sum up what we have heard from the experts here, that we still are a long way to go for treatment of fungal ulcers. But what I found interesting in Dr. Anil's saying that clinical features do help us in case we don't have the possibility of doing smears. So there also we have certain evidences that if 3 of the factors are there in clinical, we can almost be sure that it is fungal, but only for early ulcers. So all other ulcers, yes, it is a lesson we have learned that smear, at least a smear, if possibly we can scrape to get a smear, and repeated scraping is important for the management. Anybody else would like to, Dr. Mini, would you like to say something?
I think it was a wonderful discussion, especially for in the management of mycotic keratitis. We should concentrate on natamycin and repeated scraping and on identification of the corneal ulcers clinically. Thank you.
And one point I would like to stress, ma'am, just as a concluding remark, if you look at Dr. Prajna's video, he's specifically saying this is not the last study, and there are many studies going on. Cross-linking is still, we are looking at with hope that probably it may be useful in infectious keratitis at some point of time. And other photo activators like Rose Bengal is coming up a lot along with the green light. So there are still studies and randomized controlled trials that is going on, and that will be coming up in the next future. So this is not a closed chapter. We are looking at it with some hope. Anil sir, any comments?
Yeah. So, ma'am, can I make a comment? Yeah.
Yes, of course.
Yeah. Regarding the culture criteria, generally the ocular microbiologists, what they take is confluent growth in one solid medium, or moderate growth in two solid medium, or good growth in one medium plus smear positivity. And there is one more criteria which I'm not very sure about. Broth plus smear or something like that. So I think that is somewhat, that is almost taken as a standard. I think a lot of ulcer studies, they have quoted that. Coming to the point that Sujith was telling regarding, there is this RP Center has done, I think Dr. Namrata Sharma and their group has done a study on natamycin, and they have mixed it with a lot of other agents which increases the penetration. And they have found that it is very useful. I think it is pending patent. They have applied for the patent, and it is waiting patent. This one.
Nanoparticles.
Yeah.
Okay, thank you. So I think that was a very useful discussion, and thank you all for participating in it so actively. And I would like to say I found this a very useful session. Thank you so much.
Thank you, madam. Thank you all. Thank you.
Dr. Ankit, thank you. I'm sorry, Mr. Ankit, thank you. We can stop the